So I'll open the floor to questions, and again, with a plea to help us try to figure out and narrow down these questions of identifying gaps and what we really think we don't know, and can we frame the questions very clearly to be able to inform the process as it goes forward. And please do introduce yourself.
Sure, I'm Nigel Livesley from UIC India. The question's for Jishnu. It was a very interesting presentation. Sounds like great results, except for antibiotic use, polypharmacy, and injections, which kind of makes sense to me. Those are not a knowledge issue usually. They are there is a system that is set up to make those things either easier or better for the practitioner. It's easier because that's what people want. When they come to a clinic, everyone likes an injection, everybody likes pills. And it might be better too, they may be getting paid for it. So we'll just forget about the second one, but talk about the easier one. Training is never going to fix that. But what we do when we come into cases like that, which are very common, is set up improvement teams which are community-led, but working with the facility staff to figure out why they want these things and to sort of try and change practices in that way. So, and this is getting back to kind of a theme for the day, the 2 days, that we need to have the right method for the right problem. So have you thought about how to add on other approaches to address the things that training isn't going to work with?
So I don't understand well enough the market for drugs in India. So we've started working a little bit with the medical representatives. India, the drugs are super cheap, right? And the way these guys work is they have a distributor who comes to them, and some of them actually go and pick up the drugs themselves. So we don't fully understand that market yet. But one thing, so as an economist, kind of we're really always interested in what's an institutional mechanism that's going to work. So is it a legal mechanism? Is it a regulatory mechanism? What are we talking about? And one study I'd like to refer you to is, so Janet Curry, who's at Princeton, did this really nice study in China where the legislation was just completely wrong because they started giving doctors a share of profits from the drugs that the pharmacies would sell. And she sent in 2 standardized patients. She sent in a standardized patient who said, I have a cough and cold, proper history taking an examination would suggest, a viral something, and you didn't need to give antibiotics. The second one says, I have a cough and cold, and, by the way, I'm going to, my brother runs the pharmacy down the road, and I'll buy the medicines from there. The first one, 77% got antibiotics. The second one, it was 11, right? So, so our constant idea is, was there something wrong with the legislation? How do I change the incentives? And this is a very cheap intervention. And actually, China is now moving away from using the drug markup to subsidize doctors' wages. And that's kind of where we've been, but I don't understand the Indian market well enough. The one thing is my co-author, Abhijit Chaudhary, who's the head of hepatology at the hospital in Calcutta, at the government hospital in Calcutta, says, look, the big problem, and this is one thing we find, is that the fully trained doctors give a lot more antibiotics than the informal guys. And one of the things he keeps saying is, look, they're just learning from us. They want to be like us. And that's the big problem. Now, I don't understand the problem enough, but I think we need to think about it.
So, Jishnu, if I can follow up with that, it's a question that you brought up as your very first point, and maybe we can have a little bit of discussion on this, which is the assumption here from USAID is that the issue of quality is really a frontline health issue, health worker issue, rather than one which is related to policy changes at a much higher level. And that also relates to Enrique's point this morning, which is how much can really achieve by going facility by facility to achieve quality changes, and does that add up to system change? And I think you were suggesting that no, that does not. That system change is something which happens at perhaps a different level. So are we asking the right question at all with respect to methods for frontline health policy change? And is there a reason why we're restricted to that being the focus of attention for the different interventions that we're considering? Yeah, go ahead.
I mean, one quick response on what I do work on. The reason I like private markets in India is because they're unregulated. So we actually get to know for the first time what an unregulated private market works like. And the very interesting thing about the private market is it heavily rewards quality. So what we find in prices is that the providers who do, say, 2 standard deviations more of the checklist are charging about 200% more than the providers who don't. So the market actually rewards quality very, very strongly when it's perfectly unregulated. I mean, at least that's what we find. We find that in Kenya, we find that in India, we find that across multiple illnesses. The problem has been there is no link between quality and wages in the public sector. So the repercussions have been very interesting because the public sector wages are about 6 times higher than for the private sector, which is, again, one of those things that people don't realize because you look only at the top 1% and the rest of the 99% is not the case. So what's been very interesting is we've been wondering why these private medical colleges have been setting up, which are very low quality. And I've just been hanging around the cafes and chatting with these guys, and they're very clear. Look, with a degree from here where the professors are not there for 80% of the time, what I'm going to do is get the degree and set up in a slum in the city. But I'm going to apply for a government job every year. And the government cannot pay me a different wage depending on where I did my degree from. We have legislated all of that out, right? So it's completely fascinating how the lack of the very high wages in the public sector coupled with no link to quality actually moves all the way back to our medical training system, right? And what's happening on that front in a very complex kind of interaction.
Thank you. I have to admit, I'm getting a little bit lost. The discussions are all very interesting, but getting back, maybe I'm being overly concrete, apologies, but just a few thoughts on this larger question of identifying gaps and solutions. The first is that if you want to talk about gaps, the first thing I think one needs to know is, well, what all has been done? My team spent 9 years trying to figure that out, and we still don't know because it's just there's so much of it, and it's very hard to find. And even when you do your best, you find that databases get or searches get outdated almost, I guess, instantaneously by definition. So that's one thing. I think if we want to really tackle this question, there needs to be some kind of clearinghouse, some place where we can know what's been done. Otherwise, how do you know something's not there? The second practical point, that there's no, at least that I know, there's no universally recognized taxonomy of strategies to improve performance or quality. So 2 people could be talking about the same thing, but they're using different words, so they're not communicating, or vice versa as well. And I think that's really, if we don't have a taxonomy, I feel like the field will struggle. Another point is, what's the definition of enough evidence? Right? Because how many times do you have to study something before you say, okay, we don't really need to do any more studies. We think we know enough about this. And that gets into issue about understanding the effectiveness of different interventions in different contexts, which, again, we don't really know how to measure context very well or how to characterize context in a kind of systematic way that everyone can talk about with the same language. I think it's a huge priority if we want to tackle this. And then finally, and I think this is really, really important, there's not enough repetition. Maybe it's just not glamorous to test somebody else's quality improvement approach. But I can tell you that in the nearly 500 studies that my team has identified, there's something like, 80 or 90 distinct strategies, again, depending on how you define a strategy. And the vast majority of them are only studied by tested by a single study, some of them 2, and then much, much fewer, only a handful by 3 or more. And so there has to be some sort of reorientation or some kind of, incentive or something for researchers to repeat and replicate other people's work. It's fundamental to the scientific method, but somehow I think in the culture, people aren't particularly interested in that kind of repetition research, replication research. Thank you.
Thanks. That seemed more in the nature of a comment, so I'll take a question from here, Tana.
All right, thank you very much, and thank you for your presentations. My question actually is to Jishnu. I have several questions, but I will focus on one. And the one is actually directed at your last slide, where you did say that randomized control trials are possible to evaluate complex interventions. So my question is really, how much did it cost you to do this randomized control trial? And in your opinion, would the cost be prohibitive when looking at large-scale interventions? Thank you.
So the cost was $80,000. It's a very low cost in part because I had a lot of the systems set up relative to what's out there. I do a lot of trials, and the World Bank does a lot of work on different things. And the one thing I've noticed is I feel we are going around it wrong, because every time we do a trial, the group who's doing the trial sets up the entire data collection, right? So the way the US works is there's a system of administrative data that's flowing in all the time. And then there's interruptions to that administrative data, which could be experimental, like an RCT in the Oregon Health Experiment, or it could be variation across states. We have that with the DHS now, and there's some fascinating work that's come out of there, but we haven't had any of that administrative data come in, which would dramatically decrease the cost and time of trials in these setups. So, I mean, again, my plea again and again is, if you want to think about these 6 strategies and think about evaluating them, really think hard about setting up 6 surveillance sites in 3 or 4 countries where you're interrupting with these strategies coming in, but the data are flowing all the time from all the surveillance sites so that we have control and treatment groups. And it seems that's the big public good out there, right?
Yeah, I'm Dr. Thompson Akwa with Health Consulting International. My comment and questions is to the panel. I would make this comment. Basically, we should not lose sight of the input of faith-based organization in healthcare. And I don't know, in all the presentations, I haven't heard any comparative studies as to the cost effectiveness of faith-based practice. That is based on compassionate care and ethics, which leads to high quality care at very low cost, which has been discussed at certain fora. And I think when we had the 50 presidents from Africa visiting Barack Obama, USAID ran faith-based studies on some work which has been done, especially in healthcare, and the World Bank is also interested in that area. So I basically am interested in why we have not really had inputs on the successes in terms of quality at low cost that most faith-based organizations in healthcare are showing in their reports. Either we think that it's not necessary and they should not become policy issues, or we are deficient in instruments, to carry out those comparative studies.
So is your question
why
we haven't
have
actually
the input,
the faith-based as an explicit additional variable in the study?
Yes.
I see. Nynke, do you want to take that? And do we lose Ed?
Yes, this is not faith-based.
Yes. And maybe Alex can respond if there's anything in his databases.
I'm not quite sure how to answer that question. I would say that we work generally with both faith-based organizations and public organizations, and that it's very nice to see that there is a similarity of approach if you're really looking at, how quality improvement is attempted, at least. Maybe to make a comment on what both Alex and yourself, I think, are also alluding to, that, of course, there's a lot of work being done that is repetitious. So all hospitals that we work in routinely, for example, do clinical audit. It's not studied, it's not reported. They perhaps are reported in management reports or accreditation reports or something like that, but they don't enter the literature as peer-reviewed publications or grey literature even that you would include in analysis of what works. And I think that's a limitation of how we look at evidence, actually.
Okay. Nachikeet.
One concern I have, maybe Ramanan, you could address it, but maybe others could as well. A lot of our work and data that we've been seeing is about proximate impact. But what we're really interested in is the equilibrium impact. Where does the system settle when you go in a particular direction? For example, Jishnu's work, this Calcutta work, my own anxiety is if we go with literally the proximate impact and say this is a good idea, the equilibrium is disastrous. Because what we are now saying is untrained providers with little bit of training will become the dominant providers in the system. 20 years later, you don't have a health system, even though you got a good proximate impact. I'm just wondering, how does one, in some ways, I feel maybe we are asking the wrong question. We are saying how many lives saved. We want to know what is the good health system outcome that will come out of this. And I don't think we will ever be able to get data to answer that question. I think we will have to build our models in our heads, come up with explicit hypotheses, and then test those specific pieces. Does paying people change the way they think about things? And then take that little idea in our mental model. But I don't know, I'm confused about how much to rely on these proximate studies, which are small sample, and then we are saying, well, we will make a decision on an equilibrium strategy based on the results of these proximate studies.
Well, I don't know if I know how to respond to that, but maybe I can turn to Sheila to both answer that question and ask her question.
Okay, well, I'm not smart enough to answer that question, but I think your point is well taken. That really, I think what you're asking for is more of a health systems research perspective to be brought to this rather than the quality improvement, very focused studies. Would that be some?
I want to stay with quality. I want to stay with quality, but I want to look at quality when I did something today.
Yep.
And I put in place a strategy, collaboratives or something else, accreditation. What happens in a 20-year time frame? Because that's really what I'm truly interested in. Do I get fewer maternal deaths when the system settles? My anxiety is we may get great proximate results, but they may set us off in exactly the wrong direction. We saw this in India with the Janni Suraksha Yojana, which we commented on in our last report. You got great results with people going into facilities, but the unintended consequence was, we've gone, according to me, somewhat extreme. We've taken a good idea of an activist and converted her into a very narrow instrument, the leader lackey, and doing something pretty narrow. So that's my anxiety about how much reliance you give on proximate results in order to think about where the system will.
I think the point's well taken, well noted. I will say from my own work, I worked for 10 years in the UK evaluating the impact of the Labour government's reforms on quality over a decade. And had we had shorter timeframes, we would have understood very differently what we came to understand after 10 years. So I do agree with you. I will then go on to my question, which is really to invite an exchange between Ramanan and Jim. I think you should go back to the question that you asked rhetorically, and if you don't mind, Jim, beg an answer. And your question, I'll let you repeat it, but I think what you were asking is, do we need to get up above these individual methods and interventions and look at some of the policy levers, I think is what you were asking. But please do it in your own language.
No, it wasn't just my question. I heard that from Nynke to some extent with the facility-based investment improvement question. I heard it from Jishnu again with whether we're doing this in the question that he had on the slides, whether addressing quality in frontline sort of health facilities, trying to figure out what works there, whether that incremental change is what ends up adding and getting to the systemic change that we really want to get. That's also I guess, Nachiket's question. Are we focusing on the right place? And if I could just add 30 seconds on this, I think the answer here also goes back to a point that Nynke made, which is we're dealing with very different countries. Again, your investments in, say, Kenya or Uganda, where donor funding is about 25% of the budget, is going to be very different in terms of what it can catalyze and change compared to India, where donor funding is probably 0.2% of the budget, probably even less than that, and USAID is a fraction of that. So maybe the answer is not even a single answer. Maybe it's very different in different places. But this is a question that has come up a lot this morning, and it'll be helpful to have some thoughts on this.
Sure, I'd be happy to try to respond to that. And I completely agree that if you look at the overall levels of effort being invested in quality improvement, the vast majority of that effort is going to frontline healthcare improvement. That's definitely where the money is mostly going. I think that people that are knowledgeable about this field understand that the long-term goal of these short-term improvement activities is a national level sustained program that's institutionalized within the country, that the country will carry on by itself and that it needs to be managed at a high level. So it's not something that is totally decentralized at the facility level. And so the question for me is our strategy the right one here? And I think that the focus on facility level activities is partly it reflects the bias or the inclination of our missions, but also it reflects their counterparts in the Ministry of Health. That in general, ministries have encouraged AID to support frontline interventions that directly change the quality of healthcare, hopefully for the better. The question is that on the pathway to our longer-term vision of a national program? And the rationale that the defenders of this approach would make is you need to first show what quality improvement looks like, and then you can have discussions with policy level leaders about paying for this, institutionalizing it, scaling it up, and sustaining it. I tend to think that that's not a bad strategy, but it's true that we can't neglect the policy level discussions either.
It's definitely going to be the topic of a few more questions, I would hope. So if I could start with Nynke, Kedar. I'm sorry, you've got some.
We've been waiting for a while.
Is this on the same topic?
Yeah, actually, this is exactly.
Wonderful. So actually, you've been there quite a long time. Why don't you start?
Thank you.
And then please introduce yourself as
Kim
well.
Stover from URC and the ASSIST project. And I just wanted to talk to that point. In fact, I was going to talk to it before Sheila brought it up. I think the question that we were asked to present on yesterday, or Rashad was asked to present on, was the method, as well as our colleagues from other partners, and not what was talked about earlier yesterday on the how we implement that. And I think that this is really important because there's an assumption that we're only working at the facility level, and that's absolutely not the case. We're working at all levels of government from the beginning, and we have multiple examples from countries as diverse as Russia, different countries in Latin America, West Africa, and East Africa, where the improvement process has been feeding into policy, and policy has been feeding into the improvement process. So for instance, one example is in Russia, they were setting up new TB/HIV guidelines. They gave it to our sites to operationalize, then they revised it at the national level for the whole country. And then also how the work that we're doing at the facility level is feeding into changing policies and guidelines.
So if I can ask a very quick follow-up on that, which relates to this, what proportion of your, say, time or money do you think is spent on that policy aspect relative to what you do at the facility level?
Do you want to?
Just very crudely.
Yeah, I think it's a bit hard to answer. As far as activity costs, most of it is at the front line, but some of it is explicitly designed to address policy issues. So some of our work is 100% focused on policy. So Pierre was talking about Malawi yesterday. So let me give you an example from Malawi. We were asked to work on the nutrition program. So improving nutrition for people with HIV. And the Malawi Nutrition for HIV program is very well regarded around the world, except nothing happens. So everything on paper is in place. They are one of the 2 countries which are listed as phase 3 nutrition HIV countries, but not a single person benefits from the program. So we were asked to sort of address that. And the big issue is that it's a therapeutic feeding program, but there is no budget for therapeutic feeding. The reason why there's no budget for therapeutic food is because there's no information about the need for it. And so you have a problem that at the facility level, nobody's doing anything for nutrition, because why would you? You're not going to help anybody because there's no food to give them. But because nobody's doing anything, there is no data flowing up. And so nobody is able to advocate and budget for food. So we worked with the government and with the practitioners to address that. And we did it by setting up a collaborative. And this was an emotional plea to the providers that please give us 3 months, go and assess people to do the nutrition assessment. It's a terrible thing to do. You're going to find starving people and have nothing to do for them. But please do it. We will use that data to find food. And as Nynke has said a couple of times, there is always waste in the system that you can use. You know that somebody has money that they would like to spend, and giving it to starving people is a good way of doing that. So it was 100% of the money was activity. Well, not 100%. 95% of the money was activities at the facility level. 5% of the money was some meetings at the national level. But everything was, the entire point of the program was a policy change. And so working from 8 facilities to get some data, they were able to find money initially from external people to put into food. Then the government put in $750,000 per year into the nutrition program. They built in nutrition indicators for the entire program. So we don't talk about that, which is a gap, because we also don't learn from that. But it's a different gap. It's not that the assumption is that this isn't important. It's that we don't pay enough attention and we don't learn enough.
Sure. Thank you. So we'll have with Sheila and Julian's permission, we're at 11:03, which is 3 minutes past time, but we lost a few minutes to technology. So if we could get a few very quick comments from Nynke, Kedar, and then the gentleman over there, and then finally Rashad, and wrap that up there. Would that be okay? Thank you. Nynke, just brief comments, please.
Going back to Jim's comment, I think it's not an or thing, or facilities or policy. You well said you're looking to a path, to building a path towards a strengthening the whole system. And I think that the path is not the stones, but the way. So you need the strategy and then how to fit all the individual efforts, because I agree with you. You have to show, and Pierre has lots of experience on this. So you have to demonstrate that you can do something, and the only way of doing it is starting with some, but within a strategy. Otherwise, you're starting to collect stones and you never know where you're going at.
I'll just be very brief. Nynke stole part of my point, which was I think it's not about an and, it's definitely, not about or policy or frontline. It's really both things need to be studied and studied well, I think. My other comment was just to build on Alex's point, I think, earlier. It strikes me that this panel has the opportunity perhaps to do something that we've really rarely done in the literature on quality, which is to set some operational definitions for various elements of interventional design, as well as potentially describe some operational definitions for data and what measurements we might want to use so that we can create cross comparisons and generate the kind of evidence I think that we're trying to discuss in this meeting, but struggling to on some level. So,
great, thanks. Please.
Okay, thank you. My name is Blami Dao. I am from Jipaigo. I think we all agree that the 2 aspects of quality need to be in place in each country, the policy level and the facility level. Unfortunately, right now, what is missing really in many countries is the policy aspect. Because I'm sure if you go to any of those countries, you ask who is in charge of quality in the Ministry of Health? Nobody. And the second issue is that when you come to facility level, people we are dealing with have not even had a training on quality when they were in pre-service, when they are doing pre-service education. which midwife or nurse or doctors in Burkina Faso, where I'm from, Tanzania and Kenya has been taught about quality when there was being in pre-service education. And then we come with project trying to say, now, you have to do quality. I think that is one of the issues we need to address. It has to start from the beginning of the training. Even policymakers, they are not educated about quality of care. If you ask them, they say, okay, this is a USID project. Is that not our project? That is the issue. Thank you.
Thank you very much. Rashad.
Thank you.
Very brief.
2 quick points. The first one is the story that Nigel told is not an exception by any means. In fact, it is the rule. More often than not, we find that the policies, the standards, the guidelines, all of those are there. They're on somebody's shelf sitting somewhere in the Ministry of Health. The problem is not that they're not available, that we don't know what to do. The problem is that they're not being implemented. And I think Jishnu started by saying that when you ask physicians what they should do, 80% of them told you that they should give ORS. Only 10% of them are doing that. That is pretty much the story, whether it's a policy or a practice, that's how it is. Now, the other point I want to make is this, that Jishnu mentioned perceived quality. You mentioned that in the private sector, they know what they pay for quality, they know what quality is. I want to caution us from the notion of quality and perceived quality. Healthcare as a market has a lot of failures. One failure is information asymmetry. What the patient may perceive as being quality care may not actually be quality care. And I have practiced medicine, and I know what it's like when a patient comes to me and says, I need this injection, I want the antibiotic, and the amount of time I have to spend talking to them about, no, you do not need the injection, no, it is incorrect for me to prescribe an antibiotic in this case. And I want us to just be careful about understanding how markets truly operate in healthcare, and also not to, I mean, there is an unfortunate phenomenon, which is the physician is in this conflict of interest situation where, you go along with what the patient wants, you can actually get rewarded for it with money. And so you're really in this very tough situation as a practitioner, and we should be very cautious of how we interpret the results that we see from those studies.
So if we can have 30 seconds each from the panel, one to respond to the eloquent defense of Arrow 69 and your contradiction of that, and anything else you might want to say in 30 seconds.
I'm not going to talk about Arrow 69. So 2 issues, let me just raise 2 issues here. I think one big issue that's been raised is this proximate question, the ultimate equilibrium, and what role does research play? And Nachiket, I'm completely sympathetic with you, and I think you raised exactly the wrong example, right? Which is, you raised JSY, the Janani Suraksha Yojana, as an example. As we know, that was based on this very successful Chiranjeevi scheme in Gujarat, which won a huge Wall Street Journal award, blah, blah, blah. Nobody did the proximate research. 5 years later, when people did the proximate research, they found out that the Chiranjeevi scheme had no impact. So we would not have done the JSY if we had not done so on the Calcutta stuff, we're fully cognizant that there's an issue here. But what we are putting on the table is the idea that the private sector behavior is not malleable, is not consistent with the data, and giving you a number that you can then play with in policy discussions. And I think that's exactly the point here. We've always postulated that there are massive asymmetric information problems. We have never actually looked at a market that is unregulated because they didn't exist in OECD countries. So what we find is exactly what you're saying, which is prices strongly reflect correct treatments. Unnecessary treatments have no impact on prices. So you're not penalized if you do the wrong thing. You're heavily rewarded if you do the right thing. So most doctors do the right. If they do the right thing, they're paid higher, but then they add on a bunch of wrong things, right? And that's starting to provide nuance on what markets can and cannot do and where you can use the customer.
Thanks, Jishnu. So final closing remarks from Nynke.
Well, I'm very happy to continue in maternal newborn health because I think it's a nice focused area, and I hope that we have a history of putting together anecdotal or proximal evidence into a sort of bigger common pool of evidence. I think quality improvement has always been part of delivering maternal and newborn health. We know which methods might work, and they are generally in place but need to be strengthened. I think also that it's an example of where we have always worked at national and at healthcare facility level and linked them up. I think the level of effort would be 1/3, 2/3 on the whole. But bear in mind that donors like to see the numbers generally of what happens at the 2/3, the numbers of lives saved, and it's much more difficult to measure over time even the effect of policy change, and therefore to give that effectiveness to the donor.
Thank you. Thanks a lot to the panelists. This was a very interesting discussion. Back to you, Sheila.
Okay, thank you very much. So we're going to take a break now and then move into the small groups. They will be led by Margaret, who joined us yesterday from Boston, got the first flight out, I think. Will be leading the research group. Kedar will be leading the policy group, and Pierre will be leading the practice group. And I'll have to rely on someone to tell us where they go. But could I just suggest that we take a 10 to 12 minute break and get into the rooms. You'll then go from after the breakout groups into lunch and be back here at 1:15. And the task is really quite specific for the groups, and that is to come up with 5 priority issues or actions that need to be addressed. Okay,
So
directions?
actually,